So good afternoon, everyone. Welcome to the 2024-2025 Endocrinology Grand Round series that we start off today. And must thank all the um, people who have helped us with getting these off the ground and arranged for speakers. And Kelly, of course, is there all the time. Um, and we have Carrie who helps us with the molecular endocrinology section of it, and Copper for the pediatric group. So we'll have an exciting 9 months of these grand rounds, and so I'm as is usual, I get the opportunity to do the first one. So today I'm going to talk to you about the new craze, which is the medications for weight loss, which have been quite popular and has been talk of the town everywhere. I have no conflicts to declare for this presentation in particular. So, so the broad outline, I'm going to go through some of the things about this particular medication revolution that we have had. And their role in weight management and in terms of the outcomes. And also talk a bit about weight regain, which is a critical problem in management of obesity. As the saying goes, one can very confidently say that it's not difficult to lose weight. I've done it many times. So then talk a bit about the body composition changes and weight loss. There has been some concern about whether the body composition changes that occur with, especially with larger amounts of weight loss, are of some are deleterious, or what should we do to prevent excessive loss of skeletal muscle mass? And then some of the limitations of incretin-based therapies. And there's a very nice review, I think it was last month, talking about addressing diet and exercise recommendations for adults with who are using anti-obesity medications. So I'll go through some of those. So this was on the cover of Science. So obviously it is very important.
Okay, got it.
So in Science in December, they put out this cover talking about the breakthrough of the year in 2023 as the GLP-1 agonist drugs reshaping medicine. And they had a nice article on the whole science behind all of this, and also address some of the difficulties related to cost and health equity and those kinds of things. So, for those of us who have struggled with use of anti-obesity medications, what we realize is that the new generation of medications are really revolutionary in the sense that in the past, there's a lot of hesitancy to write medications. Now, one of the interesting things is that, the start of this, there was a lot of interest in thyroid hormone because we know that having thyrotoxicosis causes weight loss. So the idea was that if you give more thyroid hormone, that will be better. So of course, when you do that, you also get tachycardia, you get other side effects of thyrotoxicosis. So that idea was shelved. Although more recently, with respect to one of the obesity-related complications like NASH, the T3 beta agonist, thyroid hormone beta agonist, thyroid hormone receptor beta agonist, have again become something that we can use for management of at least an obesity complication. There is also some weight loss related to it. So it has kind of come back. Prior to that, we had prior to the newer drugs, we had amphetamines that came out in the late 19, somewhere in the middle of the 1950s. Again, they had a lot of addiction potential, especially the initial ones, so they did not become popular. Then we had anorectics and antidepressants that came out, and due to a variety of complications that they had, they were not, they most of them stayed for some time and then they went away, and it's only in the last 10 years or so that we have been using the GLP-1 analogs for weight loss. Although I must say the GLP-1 analogs were initially used for treatment of diabetes much earlier than that. But the straightforward approval, first approval of a GLP-1 analog for weight loss was liraglutide, the Saxenda. And that happened about 10 years ago in 2014. Semaglutide initially, of course, was approved for diabetes, but then it got approved for obesity only in 2021. So it's a newer drug. So it's only in the last 3 or 4 years that we are seeing a huge increase in our understanding of these drugs and how they may be helpful. So this one here lists all these different drugs, and you can see here some of these, like you have HCG. People will have heard about there's something called a HCG diet, where they give you HCG and then they also put you on a diet. It's very strict. And I think it's the strict diet that made people lose weight rather than the HCG. But, it was ineffective. So you can see here that the history of this had been full of both a lack of effectiveness and also complications. The side effects were too much. And that was the reason why it was not medication as a way to treat obesity was not very popular. So one of the biggest problems was, as with most other interventions that we knew other than bariatric surgery, before the introduction of GLP-1 analogs, the biggest problem was weight maintenance. You could get some weight loss, but you could not maintain that weight. So this is a study that was published by Dr. Jim Anderson, our good friend from University of Kentucky, who was well known in the field of obesity research. And this is a study looking at a large number of patients who were on some weight loss interventions. Some of them were medications, but mainly with low-calorie diets and very low-calorie diets. And one of the things that you see here is the fact that the weight loss plateaus. After an initial weight loss here, this is the higher, the VLCD diets, which can get you more weight loss. So one of the things that they wanted to point out here is that if you have an initial weight loss that is very high, you also end up with a higher weight loss. But at the end of the day, you're not going to get a lot of weight loss. You're looking here 5 years down the road, you're getting about 6 kilograms of weight loss, or 6 or 7. And with the other interventions, you're getting 2 or 3 kilograms. So there's a very small amount of weight loss that was being achieved. So the biggest problem that was there was that the difficulty in maintaining weight loss. And that is a problem that occurs with both diet and with the initial medications. So why does that occur? And there's been a lot of work trying to figure this out, because that is really the key to trying to get long-term success with weight loss, which is how does the body regulate body weight, and what are the mechanisms by which weight loss is being prevented. So one of the things that happens is that when you try to initially do weight loss, there is a thing, it is the psychological thing about the instant gratification of food. You can stop that. And also, they also see the weight loss, which is one of the reasons why when people go to a very low calorie diet, and they lose weight straight away. They lose 5 or 6 pounds in the first week. They're motivated to continue because they've lost some weight, you know. So there is this motivation to do that. So there's a psychological thing that they feel happy now. And then, you know, you also need some strong behavioral support, you know. So, and then you have pathways, you know, which are much more stable early in the process of weight loss. And then there is some changes, the changes in leptin and the feedback response for energy homeostasis do take some time to occur. So you will get that initial weight loss with a variety of ways that you can do it. However, when you come to the weight loss maintenance phase, that means if you're, you know, 6 weeks, 8 weeks down the road, you will start having some difficulty, which means that you can maintain a diet which is very low in calories, or if you're using a low carbohydrate diet, very low in carbohydrates, or whatever diet you're using, because every diet that is effective in weight loss, you have to give up something, you know, and mostly give up something that you like, you know. So what happens there is, you know, people think about this as a lifelong sentence, so they start hating that whole process. And then you have the, you know, central pathways kick in, where you have increased hunger, looking for reward, drive to eat. Those all come back. And there are metabolic adaptations, whereas there is a reduction in resting energy expenditure. So now the reduction in food intake that was done is now neutralized by the reduction in energy expenditure. And then, of course, there are changes in the adipose tissue, which fiercely defends its own ability to store more fat. And so there is a reduction in leptin. So this is one of the key things in some elegant experiments in the late 80s, you know, Libel and Rosenbaum, they had shown that if you can take individuals, make them lose weight, and their leptin levels drop, and you infuse them with leptin to bring the leptin level back to the initial level, they can continue to lose weight. Of course, it's a tough experiment to do. It can only be done over short periods of time. So this was done in New York at Rockefeller, and very nice articles that showed the role of leptin. But of course, leptin as a treatment has not been that effective, mainly because difficulty in synthesis, the short half-life. There's so many other things which and leptin resistance in obesity. So there are many reasons why it did not translate into an effective treatment for the common types of obesity that we have. So so that was the reason. So, you know, weight loss maintenance becomes more difficult. That's why you go back to where you have less energy expenditure and increase in intake. So you're going to neutralize that. So this cycle will go on, you know. So that's the problem that you have. So this was a study that was published early. I mean, this is a kind of a effort to study the physiology of weight loss plateau in the current setting. It means to diet restriction, GLP-1 receptor agonism, or bariatric surgery. What happens to them? You know, so this was done. You know, Kevin Hall, who is at the NIH and has done a lot of studies on energy metabolism and balance. And they have a lot of data from studying energy balance in lean individuals, obese individuals, people on medications, all of those. And so they use mathematical modeling to, you know, figure out how to, you know, what happens when you give either a medication or you do bariatric surgery. So the mathematics is too complex. I'm not going to go to that. But basically what they showed here is this. The first two are calorie, you know, restrictions. You know, one is the total calories. So these are studies that were ongoing in which they modeled these based on data that they had. So what you have there is that, you know, the top one, the calorie phase 2 study, that is reduction is a reduce in energy intake. The second one, diet fits, is a carbohydrate restricted diet. So that means you can change macronutrient composition or you can change total calorie intake. Then you have tirzepatide, you have semaglutide, and Roux-en-Y gastric bypass surgery. So what you can see here is that this talks about how much weight, weight change there is. Okay, and here is the calorie things that happen. So what happens to energy balance? So you can see here that there is a decrease in energy intake that occurs, but then very quickly it goes back up. And it takes a bit longer, but there's a greater reduction here with the carb restricted diet, and then it again goes back up. So one of the unique things about the newer medications is that these effects, I mean, it takes longer to get to this point. You must realize that these lines look the same, but the time is extended here. This is 24 months versus this is 12 months. So of course, the longest that you're going to get, and also you can see the calorie deficits that you're looking at. The difference between bariatric surgery and the medication here is, you're getting to 700, 800, whereas here with bariatric surgery, you can get reductions in the thousands. So you're going to get a much greater reduction, which lasts for a longer period of time, which is why you're able to get sustained weight loss. So you have to be able to do that. And there are mechanisms as to why does that happen. So the Roux-en-Y gastric bypass will cause a persistent, results in a persistent magnitude more than threefold greater than diet restriction and more than twofold greater than either tirzepatide or semaglutide. And all interventions except diet restriction substantially weaken the appetite feedback control. So one of the things about diet restriction is that they start feeling hungry, whereas with these interventions, you actually don't feel that hungry. So that way you're able to maintain that thing for a much longer period of time. So this is the mechanism by which these are occurring. So the energy expenditure, 300 to 400 calories per day, less than predicted, mainly due to decreased physical activity. So when you lose weight, you are assuming that you're not going to, you are spending the same amount of energy as you were when you were obese, but that's not what is happening. The second is that with some of these medications, there is delayed the energy intake. There's delayed satiation, decreased perception of the amount of food that is eaten, increased response to food, and decreased restraint in response to food. So those are things that actually result in this difficulty that you have. So these are the mechanisms by which the autonomic nervous system, neuroendocrine pathways, and changes in muscle that occur with weight loss that actually result in the difficulty with weight loss maintenance. So these are areas that are addressed by the some of the medicines and also by bariatric surgery. So this one here gives you what happens to changes in in body composition and energy balance. And 35 men with overweight, their age was 40 years. So there's a 2-year intervention, and they had reduced energy intake by 25%. So this one shows you what happens to their body weight and what happens to their body fat. And you can see here again, your energy expenditure goes down quickly here, and then it goes back up. So the way that you will be able to maintain weight loss would be if this going back is not, at least you should have this persistent effort is what is needed to, close this gap. So if you're here, you will maintain weight loss. That is what you will need to be able to sustain weight loss. So that is the GLPs were initially, identified mainly as peptides that were involved in the regulation of gut motility and pancreatic islet function. That was what they were initially recognized for. They all come from the proglucagon gene, and they're differentially processed in different tissues. So whether it is happens in the brain, the pancreas, or in at other sites, so or the gut. So that's where they're you develop different proteins. Now they have a very short half-life, and the main thing that in the development of these medications that mimic GLP-1 action through binding to the GLP-1 GLP receptors is to modify them, and there are different ways of doing it. This is an exendin 4 analog, which is exenatide. Liraglutide, here again you have a fatty acid that is added. Dulaglutide, you have two of these, and there is a binding, a bridge that is created, so that is why it works longer. Semaglutide has a, kind of a linker molecule here, and then it has a fatty acid, so it becomes longer than liraglutide. And tirzepatide has other modifications here, which make the drug last longer. So these are all modifications, and this is lixisenatide. So these are the GLP-1 analogs that we currently have. Of course, tirzepatide is a multi-receptor agonist, so it's a GLP-GIP agonist. We'll talk about that a bit later. So here, the modification not only makes it bind to the GLP-1, but also a GLP receptor, but also the GIP receptor. So the main thing that it is doing by, with the GLP is this one, satiety is one of the things that it helps. But the bigger effect is this, where you have the long-term adaptive response to weight loss, and it blocks that, so that is what, if you prevent that adaptive response, which basically means that you're going to have more hunger, you're going to be less, burn less calories. If that can be blocked, then you will have longer durations of weight loss. So that is the main thing that happens. If you go into depth of all of these things, we actually don't know exactly how they work. That's because most of it of the physiology of this were initially directed towards how they regulate glucose metabolism and insulin secretion and all of those. But the weight loss thing really came about as a side effect of these drugs. They were initially developed for treatment of diabetes, and one of the problems that was there was that you needed a higher dose. And when they tried to increase the dose, they noted that patients got more nauseous. They were not eating much, So then they said, okay, maybe we can make longer acting drug, thing. So it will give you weight loss and this effect. So that's one of the reasons why, the main side effect of these drugs is nausea and vomiting. And that is also the limiting factor. But that's also one of the things that led to the development of these drugs as weight loss medications, when initially people started using it for diabetes and people were complaining about not being able to eat much. So these are the sites of action of these different drugs, the GLP-1 receptor agonists. So if you look at it currently, what medications we have available, we have GLP-1 receptor agonists. We have naltrexone bupropion, okay, which is the Contrave. And then we have the phentermine topiramate combination, Tocilizumab. We have orlistat. And then we have the GLP-GIP dual agonists. These are the drugs that are, of course, the longest survivor for all of these is phentermine. Phentermine has been around for a long time. It is effective, but the amount of weight loss that it gives you is not as high. But there are people who would swear by it, and I have patients who don't want to go off of it. They haven't lost a whole lot of weight, but they don't want to go off of it because they're afraid they're going to regain that weight. They're also on a GLP-1, but they also still want to be on phentermine. So no, it's not approved for long-term use, but off-label it has been used for decades as for long-term use. So, but yeah, one has to be careful about that. But this is not limited. This family, we have a whole new bunch of drugs that are available now. You have the triple agonists, which includes GLP, GIP, and glucagon triagonist, which is retatrutide. And then you have the PYY agonist, receptor agonists. Uh, um, then you have the amylin receptor agonist. So amylin, for those of you who are new to the field of endocrinology, amylin was available and is still available as a drug. It's called Simlin. It's the amylin. It's a longer-acting amylin peptide, and so it decreases appetite and decreases glucagon secretion, slows gastric emptying. So it does everything like a GLP-1, except that it doesn't increase insulin secretion. And it's made by the pancreas, not by the gut. So and there is, I'll come to that. There is a combination drug which includes amylin analog and semaglutide, which is being studied. You have the SGLT2 inhibitors, which we know can also cause some weight loss. And then you have some newer agents, glabridin analog, oxytocin, leptin sensitizers, vitamin E, and then there is a taste receptor activator. So there are different drugs that are in development which can work at different sites. So the pipeline of these drugs is quite large. So hopefully we'll find something that is more effective. So if you look at the currently available drugs, you can see here that drugs such as orlistat or the phentermine topiramate have much, very limited amount of success as compared to semaglutide or tirzepatide at different doses. So you have a significant difference there. In terms of how much of weight loss these drugs can cause, certainly the newer drugs are much more effective. And so that's one of the reasons why they are popular. Plus, we have some outcome studies that demonstrate the benefits in terms of long-term outcomes, particularly related to cardiovascular disease, that make them the preferred medications for this. So this one here talks about these, one of the things that you see here is that when you add more, you're getting more of a weight loss. This is the triple drug, the GLP-1, GIP, and glucagon receptor agonist. And you can get, this is the average weight loss, 24.2% weight loss, which is a very high amount of weight loss. This is a 48-week duration. This is also a weekly, injection. And of course, here the number of patients studied is small, but still, this is in larger numbers also, it has been about the same. So you can see that, the GLP-1 glucagon agonist, survodutide, then uses the GLP-1 amylin analog, which is carsigma, and then you have the triple agonist. So, and they all also have effects on glycemic control. So again, it has similar patterns where you have better outcomes with combinations of multi-receptor agonists. So this one here is looking at multiple signaling pathways that they work on. So you have, they can work on the small and the large intestine related to the, these are, GLP and GIP are made from the small intestine and the large intestine, and then you have the pancreatic effects that they have, the effects on adipose tissue. There are some effects on bone, GI system, so it's mainly gastric emptying, and then there are significant effects on the central nervous system, effects on liver, and then on the heart. So there are GLP-1 receptors and that are distributed, and glucagon receptors, they are there, widely distributed, and that's one of the reasons why you can get, effects on multiple organs, which are hopefully beneficial. They are difficult to study, to tease out all of them. So that's one of the reasons why, one has to be careful to try to figure out what each one of these drugs is going to do. So these are the drugs that you have. This is the single agonist, which works mainly on the brain and the adipose tissue. You have the GLP-1 receptor dual agonists, and then you have GLP glucagon receptor dual agonists, which are working mainly in the liver, the brain, and the pancreatic tissues. Then you have the triple agonist, which has effects on multiple organs. What drugs are they? So these are the ones. You have the GLP-1, the GLP-1 receptor, GIP receptor co-agonists are tirzepatide is the thing that we already know. There are two other drugs that are in development. Then for the GLP-1, you have all of these, exenatide, liraglutide, dulaglutide, semaglutide. And then you have the triple agonists, of which retatrutide is the one that has published data in the New England Journal last year. And then you have two other drugs that are also in phase 2 or phase 3 trials. And then you have the GLP glucagon, by co-agonists. And again, these have also been working through their pathways. And one of the things that was published recently was their effect on NASH. So they have significant impact on reducing liver fat without increasing fibrosis. So that's one of the key things that has been there. So this one just outlines the same thing, looking at the other proteins, which is the gut proteins such as PYY and amylin. Activation of the receptor. This is mainly in the brain. So this is the data that we have on the once weekly semaglutide in overweight and obesity, and you can see here that the weight loss extends for a considerable period of time, and 43.7% of participants had prediabetes and might have responded differently. So that's one of the things that we have to keep that in mind. So because these have been studied in a large, and a heterogeneous population, it's sometimes difficult to figure out and tease out all the mechanisms by which it might be working. The tirzepatide data, again, you can see here there are dose-dependent effects, and you get even more weight loss. And then, the percent greater than 5% weight loss at 72 weeks, which is here, you're getting 90% of the patients getting to that level. And this is different doses, and you're looking at what is the percentage who achieve even, looking at adverse events. So you do get the higher, you get the nausea and vomiting higher if you have, and then you have diarrhea and then constipation. So the GI side effects are certainly a major concern for all these drugs. And I said, one of the ways to try to do this was by trying to make them longer acting, because you must remember that the physiological GLP-1 is short acting. It's very short acting compared to these. So this is the triple hormone and agonist, and you can see that the weight loss here is even greater than the ones that have already been approved. So I won't go through all the cardiovascular data. This is just to show you from the congestive heart failure point of view that semaglutide in patients with preserved ejection fraction, it does help with. So one of the things that made me talk about this is because just about a couple of weeks ago, I had a patient at the VA who had congestive heart failure, and he was on semaglutide. And his cardiologist called me and said he wants him off of the semaglutide because he had lost too much weight and he could not exercise because he feels weak, you know. So that's where the question comes up, you know, okay, you know, there's a change in body composition. You do lose muscle mass. And so what are we going to do? I mean, he was on SGLT2 inhibitor, he was on metformin, he was on, you know, the only thing, other thing, you know, he was actually on a low dose of insulin too, you know. So if I take him off of the medication, I have to give him more insulin, and he will gain some weight. But he had lost weight from somewhere around 190 pounds to 125 or so. So he had lost a lot of weight. His BMI had come down from 32 to 22. So he had dropped. But then that's the issue that is there, that is still there. I mean, it helps with congestive heart failure, but at the same time, there are other issues that one has to keep in mind. So this is a summary. This very, you know, this in endocrine practice earlier, and I think this was in April. They have a very nice summary of all of these different drugs. And this is the oral semaglutide is not yet approved. The dose is higher than the Rybelsus that we use. Is 25 and 50 milligrams. The highest dose Rybelsus is 14 milligrams that we use for diabetes. And these are the drugs that are in development. Of this, the orforglipron is actually, it's not a peptide. It's a non-peptide GLP-1 agonist. So it works, you know, it's not a peptide thing. It's an oral medication, but it is an agonist. So that's the only thing that is different. It's still, you know, not approved. I don't know if it is approved in the UK. It might have been. And you have numerous studies. I mean, we have multiple studies looking at the effects on cardiovascular function, diabetes, mortality, liver, kidney, everything, you know. So there are a number of studies that are being done with these drugs to try to better understand these. And also, certainly we realize that this is not the end of the road for these things, because now GLP-1 has effects on multiple sites. It has effects on the brain, the liver, the pancreas, the GI tract, and the heart. So its effects are going to be at multiple sites. And the thing is that from the look ahead trial and some of the other obesity trials, what we had found was that how much weight loss do we need to get benefits in terms of, you know, reduction in blood glucose and triglycerides, effects on systolic blood pressure, lipids, and then you know, improvements in sleep apnea, NASH, and then you know, remission of type 2 diabetes. However, what they have found is some of these drugs is that they can do that with lesser degrees of weight loss, and that is primarily because they have other effects. You know, for example, albiglutide, which is no longer available in the US, it was withdrawn from the market. The amount of weight loss you get is very little with that. However, its effect on glycemic control and prevention of diabetes was, you know, as good as the other drugs. So that means that they're working in mechanisms that are different from just weight loss. But if you want weight loss alone, you know, in general, you know, you can get this degree of weight loss from these medications. So, you know, that's one of the things that you have, where if you want to get more than 15% weight loss for in a type 2 diabetes remission, you can get that with semaglutide. You will not get more than 30% or so who will get to that degree of weight loss. So that means that will be the percentage who will get it. But as when you look at bariatric surgery, you can get a much higher number of people who will go, who will be able to reach that degree of weight loss. So, and that is, you know, these are the multiple effects that you have, some of the mechanistic things that are there that work at multiple sites. So whenever you have these kinds of effects, you know, one has to be concerned because it seems to be working at multiple sites. We don't know whether all that it does is good or bad, and what these receptors are doing. So one has to be very careful. These are nice reviews on this in Journal of Clinical Medicine and also in JCI. So what are the limitations? Are these all these wonderful drugs? So you have a few things. One is the side effects. Second is recidivism. And then you have change in body composition, cost, and which in turn exacerbates social disparities because only people who can afford it will be able to use it. So this is from December JAMA, under medical news, and it came up as semaglutide popularity soars, rare but serious adverse effects are emerging. So, and as I said, today, my last patient stopped taking his semaglutide because he read in the paper that people are going blind. He refused to take it. I told him the thing. He said no. He was on tirzepatide before, but there was a shortage, so he switched to semaglutide. Now he says, I can go back to Mounjaro, but maybe Mounjaro will have the same thing. I don't know, but nobody reported it. But he was not going to take it. He's got poorly controlled diabetes. A1C was 8.8. It went up. I mean, he had an A1C of 7.8. Now it's 8.8, and he's gained weight. All of those, but he doesn't want to take it because he's concerned about side effects. So the most common ones are GI side effects, and some of them are more severe, such as gastroparesis and bowel obstruction. Then there are anesthesia-related complications, which people are trying to work through to find out who. Pancreatitis, 9 times higher risk than with other medications. And then there are some questions about mood changes. So this is a Canadian study that had looked at it, and they had some concerns about changes in mood. And a more recent analysis of the data does not indicate that there is any suicidal risk with this. And again, one must remember that one of the very effective drugs, the endocannabinoid inhibitor, rimonabant, was introduced and then withdrawn from the market because of suicidal risk. So, everybody likes to eat, and if you can't eat, you can get depressed. So, but anyway, I mean, there are more complex mechanisms than that. But there is some caution to be used. I mean, you just don't want to give it to everyone. Severe reflux, that is known. And anaphylaxis and angioedema have been reported. I have one patient who had angioedema. And then the non-inflammatory ischemic optic neuropathy that was reported in JAMA, I think it's called JAMA Ophthalmology, from the Massachusetts Eye Infirmary. So you have, a bunch of side effects. The most common, of course, are gastrointestinal side effects. And this is the large Canadian analysis that looked at a huge number, a database looking at different patients who had received a variety of drugs, and they were looking for GLP-1 drugs. So they had 4,144 with liraglutide, 613 with semaglutide, and then you had 654 with naltrexone bupropion combination. And they looked at the thing and said that the GLP-1 agonists associated with increased risk of pancreatitis, so that was a 9-fold increase. Bowel obstruction was 4.22, gastroparesis 3.67, but not with biliary disease. So this is a retrospective chart analysis, so there are certainly significant drawbacks in these kinds of analysis, and that's one of the things that we know that we have to be careful. That certainly the main things to be concerned about is gastroparesis, pancreatitis, and bowel obstruction. So that is a thing that we are still there. So this here looks at the fact that there is recidivism. That means if you stop the medication, you will gain the weight back. So that means that you have to take it forever. There are some studies that are now looking at, can you give it every other week? Can you give drug holiday and give them after a month? Both in terms of trying to maybe reduce the side effects or reduce the cost and things like that, But the thing is that there is a weight regain. But one of the things is in the SURMOUNT trial with tirzepatide, they lost weight, but when they stopped the medication, they did not regain all of it. So they were still at 10% weight loss. They had a 21% reduction in body weight, but then at the end, when they went off of the medication, they didn't regain all of that weight. But we don't know who will revert to fully back to their initial weight. So that we should know that this is drugs with tremendous amount of efficacy, but the fact that you have to take it forever is something that one has to be careful about. And again, that is what makes people want to develop new drugs and see if they won't have this problem. So this one here looks simply at body composition changes that occur with weight loss. So whether it's diet, incretin agonist, or bariatric surgery, it's the question of loss of lean body mass. So when you lose weight, you're going to lose fat and you're going to lose lean body mass. The greater the amount of weight loss, the greater the amount of loss of lean body mass. So there are two things in this. One is what is called as, is there a disproportionate loss of muscle mass? That is the thing that is of concern, So if it is proportionate, it's kind of adaptive to the weight change, then there is no problem. If it is not, then you will get into trouble, that you will have what we call a sarcopenic obesity, which has its own bunch of problems. So one has to be careful about this. So this is a study looking at changes in lean body mass with the GLP-1 receptor agonist. So, we are getting to this where we have significant weight loss, almost comparable to bariatric surgery in some of these agents. And the thing is, we do see changes in muscle mass and whether there are interventions that can prevent that from happening. So this is just two examples where you can see, you can get either weight loss and a muscle mass loss that are proportionate, which makes it more likely that is an adaptive thing. And there is a maladaptive weight loss where you can develop sarcopenic obesity, where there is the drop is going to be excessive, So if that happens, then you may develop that, again, measuring muscle mass and how you're going to interpret it, because if I simply go by kilograms of muscle lost, that is one way of looking at it, but you really need to adjust it for changing BMI. So you'll have to look at what you call skeletal muscle index or some other measure. The other better way of looking at it, especially in the geriatric population, which we use nowadays, is when we look for sarcopenic obesity, it's not muscle mass, it is muscle strength. So that means quality of muscle. So if you're interested in either studying it or from a clinical practice, trying to make sure that they're not losing too much muscle, you have to have some measure. But usually it can be done by grip strength. And also, walking and walking may require some balance, but grip strength is one way of looking at these things. So you can see here that this one here, simply looking at muscle volume, change in muscle volume with liraglutide and tirzepatide. And when you look at it here, so these are, if you get liraglutide with lifestyle intervention, which is diet and exercise, you're still going to be doing better in terms of maintaining your muscle mass. Whereas if you're just using the medication, whereas on the other hand, if you take insulin, you actually will go up. But you're not going to lose weight. That's a different story, but you can maintain the muscle mass, and that's one of the things that we will have to look at as one of the options that you have. So this study that was published in 2021 really looked at liraglutide and exercise, or both. So this is a very good example of looking at what happens to you lose weight. Exercise with liraglutide actually had the most weight loss, whereas of course placebo they gained weight. And then you have change in weight, and you can see here exercise change in muscle. Difficult for me to see that here, you know. So this essentially what you can see here is that if you have exercise and liraglutide, you will have better preservation of muscle mass. You'll have more loss of fat, and also when you look at outcomes, you know, in terms of change in cardiorespiratory fitness, and particularly with improvements in insulin resistance, you will actually find that mainly if you use a combination of exercise and liraglutide. Liraglutide alone is not going to make you more insulin sensitive. So this is this was just published in Diabetes Care earlier this year. This just compares the change in muscle in lean body mass to different things. And I was surprised that if you have ovarian cancer or head and neck cancer, you're losing less muscle mass than if you're using semaglutide or tirzepatide. So, you know, so you have, you know, it means these are comparable in terms of overall percent loss of muscle mass. And this again looked at exercise, and you can see that if you exercise, you can actually maintain, and you will maintain weight loss, and you will also be able to maintain lean body mass. So one way to avoid that is to exercise, and particularly, you know, resistance training is the way to go. And also, this is particularly that younger people will respond better in terms of preservation of muscle mass and increasing muscle mass with that. Men will do better than women in terms of effective exercise training on lean body mass. So this one here says, so what? So this is a nice article from this year from JAMA. Does it really matter? At this point, if you adjust for the average patient who is on a GLP-1 analog, the weight loss is kind of and the loss of muscle mass do not seem to be disproportionate, you know. So you know, you will lose some muscle mass, and you can see here that tirzepatide actually had a greater loss of fat mass than muscle mass compared to the other two drugs that were compared. But of course, you know, this is a small study. But this again highlights the need for you know, paying attention to some of these things. But the thing is, the data is very varied. You get changes from 20% to 60%. So there are individuals who could lose a huge amount of muscle mass. So and some of our patients complain about it. So we have to take that seriously, that it can happen. So so that's the reason why, you know, some of these recommendations that we have in trying to preserve muscle mass, which is changing diet composition, increasing physical activity, you know, targeting GI hormones. And then there are other ways that people are trying to improve it. So, and finally, I'll talk about diet. What should we do when patients are on a GLP-1 analog? What should be the diet? This is very similar to what you have in terms of obesity management in general, in the sense that there are two broad theories. None of this are proven, I mean, none is superior. One is the energy balance model, and the other is the carbohydrate insulin model. So when you look at that, you know, in the energy balance model, the primary driver is in taking in more food. In the carbohydrate insulin model, insulin is the culprit. That means you take more carbohydrate, you have, you know, it doesn't matter how many calories you eat, it's the carbohydrate that is driving the insulin. It's the insulin that is causing all of these problems. So in one model, you're trying to reduce carbohydrates, and the other, you're decreasing the total energy intake. So you can use either one of them. I mean, people have done a lot of studies looking at these different models and, you know, prescribing diets for this. And the studies are, you know, they don't give you consistent results. So in general, we can say that whatever diet the patient wants to, but they all should have, there will be some degree of restriction of calories because, and or carbohydrates, and that should be done. But they also came up with certain other things in terms of fluid intake, the total energies that you had to take, fiber, protein intake, how much carbohydrate, is better for them. And then also in terms of multiple vitamins that they need to take. So these are very similar. They're very similar to bariatric surgery recommendations, except, in bariatric surgery, there's a malabsorptive component. So you're using some higher doses of vitamins and minerals, whereas here you're using, you have to be careful to supplement these individuals with this. So this is published in last month's obesity journal, and gives you a very nice outline of what to do. And this one here gives us an overall idea of what we have to do. That is, pre-treatment, you want to kind of be sure, make them to prepare them and also assess them for their own nutritional needs, their nutritional deficiencies. What is their age, the comorbidities, all of those things have to be considered before you're starting them on anti-obesity medication. Once they are on it, you make recommendations in terms of nutrient intake and calorie intake, and then you have to monitor them for these things. The risk factors for malnutrition, history of GI tract surgery, advanced age, comorbid chronic diseases like people who are chronic renal insufficiency, those kinds of things, one has to keep in think. Unintended weight loss greater than 5% in the past month, or greater than 10% in the past 6 months. That is something that one has to look at and screen them for any malnutrition, food insecurity, or monotonous diets, poor dentition. So these are all things that one has to take into consideration. And then management of adverse GI side effects. These are critical for this particular group of patients. So this is from Lancet. This was also published earlier this year, where they have this thing about how to use medications. They have so they look at the older population and the younger population. If they are young, you can use any medication. For the older population, they want to use liraglutide, semaglutide, phentermine, topramine. They haven't used tirzepatide. I think it was a bit older, although this was written in 23, so I don't know why it was not included as tirzepatide. And then you have to see if they have comorbidities or not. So if they have no comorbidities and they're young, you can use any medication that you want. If they have comorbidities, then you have to look at different options depending on cardiovascular disease, depression, history of medullary thyroid cancer, pancreatitis, NAFL, sleep apnea. So there are different things that you can look at. So the new and emerging incretin-based therapies are highly effective. At present, they appear to be lifelong therapies, and one should be cautious about long-term outcomes and side effects. Appropriate selection of medication and monitoring of adverse effects is essential. Combining nutrition and exercise recommendations with anti-obesity would be the best approach. Now, there are some studies that have looked at polymorphisms in the GLP-1 receptor gene, and there are things that they can show that some of these will respond better than others, but we're not there yet where we can screen for a large number of people, where you can say that you have, because there's always a heterogeneity of response. So one is really interested in figuring out, can I tailor this one? So as we get more and more data, we may be able to say, I'm going to use this because there are so many different GLP-1 analogs and these combinations that are there. So that's why tools for precision medicine, people have large number of studies that they're looking at. So I'll stop here. And this is your code for your CME. And if you have any questions, we'll be happy to answer. Thank you.